Good morning, everyone. Welcome to the American Enterprise Institute. Today we are going back to the future in my latest Field of Health Policy Dreams installment. I'm Tom Miller, curator of AEI Health Policy History, with a reminder that there are no new ideas today in health policy, but also no shortage of older ones being repackaged and recycled. Nevertheless, there may be a few that need renewed attention in an updated framework, perhaps with some reupholstering. In particular, we're taking a look with some updated revisions at a book that was published by AEI back in 1995, the 30th anniversary. It was really the culmination of years of work by longtime AEI scholar Clark Havighurst, aimed at using the tools of contract law to provide more meaningful value choices in managed care as chosen by consumers seeking better options. Now that culminated decades of previous scholarly contributions, including many through AEI by Clark, essentially building the early foundations of health law as an academic field and a lens through which to shape health policy. Will those older theoretical choices have future echoes, to turn the 1964 Goldwater campaign slogan a bit on its head? I always consider some alternative titles for these events, perhaps a DNA recreation of some much older work, but I thought of something instead. I remembered how decades ago, usually it'd be in December of a year, we would have a policy week at AEI, where we would assemble all-star panels of policy scholars to discuss cutting-edge issues during the week. Sort of like an all-star game. Now today's somewhat of a health policy recreation, followed by some re-engineering. My announcing is not quite up to the Hall of Fame standards of the late, great Bob Shepard, who went from being a speech teacher in New York City to over 50 years as the public address voice of God in Yankee Stadium, retiring finally as a young whippersnapper at age 97. So Clark, you got some years ahead. But here is our starting lineup today. After some opening remarks by Clark Havighurst, batting first, playing health policy historian will be Mark Hall. That's Mark Hall. Batting second, playing business law analyst, that'll be Barack Richmond. Batting third, there used to be an echo in Yankee Stadium where you could hear it kind of coming back the second time around. Usually either Mickey Mantle or Derek Jeter. Anyway, batting third, playing health and economics synthesizer will be Jim Blumstein. That's Jim Blumstein speaking third. And hitting cleanup out of Minnesota, playing a chilly look at health policy regulation, Amy Monahan. That's Amy Monahan. So that will be our thing. Now, I should note that Clark Havighurst is in his 9th decade, still has some more things to say. About 2.5 years ago, he asked me to assist him a bit in modernizing his final book manuscript. It's up to more than a dozen chapters, and I remain confident that Clark will finish it in his lifetime, if not mine. It's called Healthcare American Style. And I certainly could never say no, because Clark's talk at a 1991 AEI conference, taking private insurers to task for not doing a more useful job for consumers, was the primary catalyst for my getting more interested in health policy long ago. So yes, it was all his fault. But before Clark makes a few opening remarks on the older background behind the Health Choices book through AEI, allow me to complete the first of, who knows, several unveiling ceremonies that recognize those who started well before us at AEI and built the scholarly policy foundations on which to try to stand and nudge ahead further. And we'll see who's coming up next. We've got 3 spaces to go. So let's welcome Clark to the stage for a little bit of the introductory background as to how we got here.
That's Donald Trump's place.
Well, he's going to blast all 4 of them. Well, let's not go into that right now. Clark, if you can come up to your opening remarks.
Sure.
Okay?
Give me a minute to get
I understand.
get my cane, make sure I get up the steps.
And those of you should know, in the deep, dark times of the early 1970s, Clark was the early real contributor to the development of health law and policy, often through AEI, with many contributions, including this book.
Okay.
Okay?
Thanks, Tom. This is, I want to explain one thing, why the color of that paperback book, okay? I chose that color because that was the color I made for my senior thesis at Princeton, and I got a good score on that color. And so I decided I'd stay with it. And anyway, the book is for discussion later. I just wanted a few minutes to sort of thank AI for all the interest over the years it displayed in my work. I got invited to a lot of their conferences and contributed to many of the volumes that they put out, and felt very close to AI for all those years. Had different roles, but always supportive. Before I tell the story of how I got started with AI, I want to tell you a little bit how I got interested in this whole subject matter, which nobody here even knows this story. This is a new one, I think. It's very curious. It happened quite fortuitously. In the late 60s, as I was a new law teacher at Duke, I was the editor of their journal, symposium-oriented journal, Law and Contemporary Problems. And I was having to produce 4 volumes every year and edit some of them. I had guest editors for others. The choice of the topics then was usually mine, and I didn't know anything about healthcare, but I turned out the dean at one point wanted me to try an issue with the faculty at the medical school. And I said, okay, the dean being the dean. And I got something organized. It turned out it was a difficult editing job because some of those people didn't write very interesting or important things, and I had to spruce them up a bit. But in the meantime, I learned a little about healthcare, and that was of interest. We produced a volume in '67, and the title of it was Medical Progress and the Law. How's that for a ringing title? And at any rate, because my name was on that issue as the editor, and only because they saw my name there, I got a call from HEW. That was Health, Education, and Welfare, if some can't remember that far back. And it was a cold call, and the fellow wanted to know, and actually the fellow in question, by the sheerest chance, was Larry Tancredi, whom some of you will have encountered along the way, and I did a little work with at that time, a little afterwards. But that was the first call, and the result of it was that the law school got a contract with HEW. And we had under that contract, I was supposed to try to generate more interest in legal writing and scholarship in the healthcare field. That was a government enterprise initiative at that time. And so I got this contract, and that allowed me to create what was called a Committee on Legal Issues in Healthcare. And national experts, most luminous of all, and most helpful of all was Guido Calabresi. And so I was in pretty high cotton there, and it was a wonderful start. Those people were wonderful resources, and they gave me ideas, and what we were doing was trying to get the law reviews around the country interested in doing healthcare issues. So we had the Yale, I forgot who did what. Harvard did HMOs, and Yale had another one that was equally sort of the history of the AMA and antitrust history. All that was very exciting, and it meant very soon that I got drawn into the field for all time. But I started with nothing when I had the first issue job, but it's been a nice and interesting area to work in, obviously. And I'm glad to join the rest of you in that area endeavor. After that early break, I had a chance. I had my first engagement with AI, I need to tell a little about that. It was possible because I'm teaching regulated industries, I knew about certificates of public convenience and necessity, which are required of utilities and airlines and a lot of other, and nobody in the field thought very highly of them. And here came some people from the health world saying we need something like that in health, called certificate of need. And I've quickly said, well, there's something we ought to be discussing at a high level. So what I did was go to my dean, who was Joe Sneed. Not many people will remember Joe, but he was a distinguished fellow. It so happened he was a board member of AEI. I didn't know that. I'd never heard of AEI at that time, interestingly. First thing that happened, I talked to AEI, says, sure, come and do a conference in Washington. And we did, and it was well attended, and people were extremely interested. And the number of the people I invited were not entirely enthusiastic about the idea. Dick Posner was one of the people we had who had already written on the subject, more or less, in general terms anyway. And that meant that suddenly I was in the AEI world, and it was very exciting. It was well attended. It was in Washington. And, you all know, many of you will remember Stu Altman. He was there in an official capacity for the Nixon administration, and he was hard to convince that there was any problem with this brilliant idea that was going to make need the only question and had to answer. And that, of course, was, we didn't succeed in stopping that movement either. It went right through Congress in the following 74, and then was repealed. The basic idea was repealed in 86, if I remember the year.
That's right.
And the result was that all the laws that were because this government had required states to enact these laws, when they repealed the mandate, they didn't repeal the laws that the states had adopted, which are still in place and often doing a lot of harm. Okay, another story which we can't get into. Another result of that conference was interesting to me was that a fellow named, I think Tom Johnson, could have his name wrong, but he and I worked on that conference. He asked me afterwards if I'd have any interest in moving to Washington and running a health shop for AEI, of all things. And this was the job Bob Helms eventually got. I, of course, had no business and no experience in Washington or in government or in any of, and I decided I had a really secure job at Duke. I had 2 young children, and my wife is still pretty young, and we were having a nice life there, had a new house, and I had job security, and that made my decision for me. Anyway, but that was a wonderfully, the first of many experiences I had, and I must say I've enjoyed it all. There was an article in 1983, Jack Meyer did a symposium, something about market reform. I've forgotten exactly the title, but that AI published that, and I had 2 articles in that one. One had to do with antitrust. It wasn't too distinguished, but the idea was that to show how antitrust might be helpful in ensuring consumer choice and some control of healthcare spending. And the other article, however, is more interesting because I observed there that there wasn't clear that antitrust would make much difference because of the extent to which medical opinion and professional standards were already baked into the healthcare contracts, the law of torts, and into the health system's entire legal environment. It was already the decisions were being made by the medical profession as they had their own standards, and those are the ones that seemed to govern. And so I wrote this article, and it said, let's see, where was the title? There it is. It's called Decentralizing Decision-Making, Private Contract versus Professional Norms. That was 1983. I think that's the first time I used the word contracts anywhere. I may have forgotten something, but it was
before then.
that article is pretty short, but I think one of the best things I ever did, because it really did break some new ground. Anyway, I wanted to call your attention to that. I, of course, worked on all through the 80s, was developing the notion of contracts and changing tort law and other things that way. And the result was that I eventually got involved in the consulting with Walter Zellman's task force of policy experts that were advising on the Clinton Health Security Act in 1993, that would have been. And I first got involved because one of my Duke students had known that I was working in Washington with one of the members of the task force. She knew that I knew antitrust law and healthcare, and so she called Zellman's attention to me. We consulted. I finally got the right to do even more, contribute more, and I wrote essentially a lot of legislative language that appears in Healthcare Choices. It doesn't appear there as a product of that effort. I decided to write the book saying that with the idea that these were new ideas, not just ones that I've been trying to sell to the Clinton administration. And so there we were. But it seemed to me the right way to tackle that. So Healthcare Choices offers, there's a proviso in there on page 50 to 55, a long, it essentially takes a big chunk of the legislation they were proposing and creates an exception as big as a barn door. But there were 6 conditions that had to be met, and we negotiated those. And the result is finally that product, that experience was good because a number of the people, and the Zellman, Alan Entov, and a few others said that they thought this was all interesting, but of course it was all too new and radical for the Hillary and Ira Magaziner, who were the political overseers of that bill. So it went nowhere, but therefore I had to write a book. And the way I got that done was to go to the John A. Hartford Foundation and say, look, I've got a lot of stuff in my head I want to get on paper, and persuaded them finally. And I said, what we'll do is you make a big gift grant to AEI, and they will publish the book and pay me to write it at the same time. So that's how we're here today.
That's the backstory.
And I'm interested to hear what's happened in the last 30 years.
Not that much.
Thank you all.
Thank you, Clark. Well, I think we've proven since that almost anyone can run health policy at AEI and in Washington. But so the prerequisites, I got involved in it because there were no barriers to entry, at least on the right of center perspective. We have a tremendous panel today. We'll go sequential, and I'll introduce them, each one of them as they speak. They're all capable of consuming such time as they may wish to consume, but we'll limit them to about 10 to 12 minutes. They can all finish each other's sentences. A number of them have co-authored articles between themselves. In another case, we've got someone who was a co-author or editor with Clark on a health law textbook. We would have had another speaker who was another editor on the textbook. So it's a little, I wouldn't say incestuous, but and it's not quite a meeting of the Duke Law extended faculty, although most people on this stage have ties in one form or another to that. I'm just coming back from the Florida game where it turns out that gator tastes a lot like chicken when you chomp down on them, but that was Tuesday night's game, as I'll just mention as an aside. All right, we're working on liberal leave today here. Our first speaker, and I should point out, let me see if I can get this back up here. I was warming up in the bullpen. I got my dates wrong. Mark Hall's book was actually in 1995, so I should have been doing the anniversary. But I told Mark if he waits 5 more years, we've got an anniversary coming up where, if I'm still around, we can do this one as well, which was Reforming Private Health Insurance, published by AEI in 1995. And that's where I learned most of what I could learn on the regulating health insurance, although I did not follow Mark when he adopted a social conscience. I fell behind on that one, but the rest is absolutely superb work. So Mark is going to take a little bit of a look at at the underpinnings of not only what Clark provided in building health law and policy, but where we a little bit of an intellectual history journey, although Mark is capable of many other things. So Mark, you can speak from there, or
Yes, I'll speak from here.
Okay,
Yeah.
go ahead, Mark.
All right, thanks. Yeah, so this will be retrospective in keeping with...
And I should say, Mark is so distinct, professor of law and public health at Wake Forest, not private health, I understand, which I always favor more than public health. That's okay.
Yeah.
And then, health law textbooks published widely. Go ahead, Mark.
Yeah. So, but my remarks that I planned were the retrospective look and then bringing it up to the present, but I think I'm going to yield to the present aspect, time considerations for the rest of the panel to touch on various topics that have showed the currency of the ideas that Clark first introduced and quickly referred to. I will say in terms of this image, is this showing somewhere that I'm pointing at the image that I'm looking at? Yeah, okay. Bob Helms made me put that Band-Aid on the cover. I objected, but he said I had to do it. And so I don't blame me for that. Poor art. All right. Sorry, Bob. All right. So I'm in a retrospective mood because I've now entered my 40th and last year of teaching. I think Clark did 40 years in the academy. We're roughly 20 years apart. And looking back over my sort of time in the field and the topics I've worked on and what have you, I sort of think that the single most influential, intellectual leader in my mind is Clark, and because he not just sort of the answers that he gave to the important questions, but the questions that he asked were questions that were not being asked prior to his coming to the field, and they ended up shaping, I think, the major component of the field that I focus on, which is healthcare finance and regulation. And so I just want to recognize the variety of ways in which that has occurred. I want to stress the difference between agreeing to the answer versus understanding the importance of the question, because that's I think what shapes intellectual history. And getting ready for the talk, I pulled up. I remember that Clark had written a retrospective himself 20 years ago on the eve of his retirement, and he sort of bemoaned the fact that the legal academy had not fully embraced all of his ideas and approaches to things, and he wondered sort of what was the point of the 40 years that he had spent, and he in a footnote, and so you get some of the best insights from Clark's writing and some of the best expression in the footnotes. I always read his footnotes. He says, I wonder if other scholars working in the field also feel diminished by the possibility that we are only playing transitory roles in an unending drama that has no denouement, only various scenes with more or less satisfactory or unsatisfactory endings, but in the end leave the policy realm with unsettled, unstable, and unresolved. A little bit of editorial prerogative there. So, so is it a merry-go-round? Are we revisiting the same ideas? Is it there's some sense of futility, wistful thinking? And what I want to say is, well, in terms of like solving the problems, yes. But in terms of how we address the problems and think about the problems, Clark really created the landscape that I inhabit. And in this same article, which is in Health Matrix, published by Case Western, he refers to the fact that his ideas were revolutionary, and a couple of times actually embraces the mantle of being a revolutionary, or quotes others that have called him a radical, because he came to these issues so much differently than had before. I counted up a couple of dozen times, used the term. So that got me to thinking, what does it mean to be revolutionary? I mean, upset everything and change everything. But it also, I think about Thomas Kuhn and his, the structure of scientific revolutions, that what occurs in these intellectual revolutions is really very much what are the different set of questions that we're asking? In one era we frame the world in one way, in the next in a different way. And by helping to bring about that revolution, again, you don't set all the questions, but you so fundamentally shape how people approach issues that we're not even aware of it. It's sort of like, I don't know, the cosmic radiation after the Big Bang, or sort of afterglow after a supernova. So that it's there. You barely notice it until you think about it, and you say, oh, well, we're only engaged in this enterprise because someone 40 years ago set out, or 60 years ago, set out in this direction. So to underscore that, I pulled off my shelf a case book used in teaching law and medicine, as it was then known at the time that Clark entered the academy. And I had this on my shelf because somehow I ended up being now the lead author of this original case book in the field of law and medicine. So in 1960, the first edition, I mean, it's unrecognizable to what we now think about as healthcare law. In an 800-page book, something resembling what's now in the field is maybe 15%, the last chapter. The rest of it is what was sort of known in grandiose terms at the time as medical jurisprudence was the name, which is essentially what aspects of the legal system are important to doctors and how can doctors engage with that. And most of that is what we would call medical forensic science. And so proving paternity and insanity and cause of death and the like. And so you have, chapter after chapter about how doctors, practice and how the medical science works and what have you. And then, towards the end, you have 5 pages on, regulatory and various aspects. And so the world then was very much, to use another sort of cosmological analogy, thinking about the Copernican revolution, heliocentric versus geocentric. It was physician-centric, as Clark pointed out already. The law was entirely focused on, what is the special expertise and status that physicians have, and how can law sort of best use and accommodate that, which is, good that the law did that, but we needed to move on from that. And so in quick order, we dismissed the antitrust exemption for learned professionals and began to recognize that really the center of our focus is not physicians, but the healthcare finance and delivery system. And so the field now is about understanding how that system works, and rather than sort of operating in some sort of formalist doctrinal mode, thinking about how the legal and regulatory and health policy system, how well is it structured to achieve the desirable ends of healthcare delivery, which are principally, and we can debate about what those are, but principally the cost, quality, and access to care. So understanding this sort of more instrumental focus on the system as a whole really brought to the field much less a doctrinal focus and much more what I call comparative institutional analysis, a phrase that Neil Comisar at Wisconsin, I think first started using. Ed Rubin at Vanderbilt is another major figure. But this approach, this analytical approach, is very much in line with what I've just said, which is you sort of identify what you hope the system will produce, and then you think in terms of what sort of broad social, regulatory, political, economic, professional mechanisms are best suited to bringing about those results. And so for any given question, and this is, I think it's Clark's work that taught me to think about this thing. Should what we hope to achieve best be done through market mechanisms or regulatory mechanisms or professional norms or contracts, as in Calabrese, torts, various aspects of private law versus contracts. And that way of framing things becomes that sort of an analytical methodology that is such a rich toolbox, and that puts in the center of our focus what I think we all agree is most important, and remains the structure of the field. So Clark, some other scholars got out a year ahead of him, but he came out with the first really foundational case book that usurped the one that I now edit in 1988, and I think maybe wasn't the most widely used casebook, but I think it's certainly the most thoroughly studied. Others like me had it on their shelf and referred to it very frequently, as well as teaching out of it a couple times before I was handed this other competing opportunity. But any event, it's in those ways that I think Clark has been and remains so foundational, and that 60 years hence, 20 years after his retirement, not cited as much as he used to be, but still in sort of his thinking, his approach to things, his way of framing issues still permeates the field. Let me just check real quick. We don't have a counter, but am I done, or do I have a couple
You're
more?
getting close.
Close,
but
I know.
We got a finishing flurry.
Okay, well, I had a list of examples, and I was going to give them, but I'll just say, at the broadest level, thinking about resource allocation and resource scarcity is one example. I think Jim's going to go into that. The proper role of professionalism, we don't want to discard it altogether, but we don't want it to be the dominant driver of things. I'm sure that'll come up in various ways. This concept of distributive injustice that Clark worked with Barack on, that I just, once I read that work, the point being that the structure of health benefits and health insurance is very much key to what the elite C-suite managers want, and then is, because of various reasons, institutional, legal, and what have you, sort of imposed on all the rank and file, despite what their actual welfare choices might be, which has a perversely regressive effect in terms of resource allocation. That insight was sort of one of the finishing pieces of Clark's scholarship, and that resonates in so many different ways. And we haven't even got to the specific topics. So antitrust, certificate of need, medical necessity determinations in insurance, liability standards, and HMO regulation, and all the rest. So with that, I will bring things to a close. I've used all of my cosmological analogies, and at risk of shifting to the worst metaphors. But it's such a great honor to first have this bullpen that I'm part of, but to be here with Clark and to recognize this immensely rich intellectual history that you've bestowed upon us.
Thank you, Mark. And we're going to have a cross-panel discussion after each of the initial presentations as well to pick on. And another thing. So I'm sure they'll have no end to that. Our next speaker is Barack Richmond, who has an extensive background. Now wearing a hat at George Washington University after earlier incarnations at Duke and time out at Stanford as well. He's spoken at a number of my events in the past. Barack is also responsible for my starting teaching at Duke, so it's his fault on that front as well. But the contributions to the field are great. More on the business of health these days, although we'll find out what's on Barack's mind. And he's, I think, going to speak a little bit more about delving a little deeper into the latest iterations of thinking of contracts in the health policy and health law sense.
And I might stand,
sure.
That's okay. So, all right. So Clark began talking about how fortuitous he was early in his career, being in the right place at the right time, being exposed to the right ideas and the right people. And that certainly is where I'm going to begin my talk. I was in the right place at the right time. I was hired, I'm not entirely sure why, at Duke in 2003, and instantly Clark was my mentor. And his teaching, his instruction, his mentorship meant an enormous amount those first 5 years I was there, and they have meant an enormous amount ever since. In many ways, Clark's is still, his wisdom is still ringing in my ears. And that's one thing that is going to be a theme of today's talk. One of the real privileges I had at Duke, and really in my career, was being part of an event that I think somewhat imprecisely celebrated Clark's retirement. He, of course, continued writing for another 20 years. It was in 2004. It was my second year at Duke. And one of the lasting memories I had of that event, it was a big celebration. Clark, as you know, was adored at Duke and in Durham and regionally. And lots of people, including several people in the room, traveled many states to celebrate with him. Celebrate what was called his retirement. And the way Clark celebrated his retirement was to talk about a brand new paper. So it's within that spirit that I am going to celebrate Clark by talking about some work that he influenced and continues to influence indirectly, and spiritually, I guess. And I will be very brief. So I'm looking at the clock. It's 10:35. I promise to be done by 10:44. Does that sound about right?
Not bad at all.
Okay, all right. So we begin with Clark and healthcare contracts, and this is, of course, the book that articulated the idea. By the way, I like this picture of Clark, but I like this picture of Clark much more. This is the portrait that continues to hang in the hallways of Duke Law School. That was a Porsche, right? That's a Porsche you're sitting on?
That's my Porsche, yeah.
Oh, yeah.
5 years.
Yeah, yeah.
It's all remembered. That picture is not in the law school anymore. They don't have room for all of Emeriti.
Oh, that's too
So
bad.
this was the basement. Karen talked them into giving it to us. It's now in a storage space at U-Haul in the neighborhood.
It belongs in the Duke Law hallways, but it continues being an image in my head, at least. So Clark was, as has been described, extremely influential in just raising the possibility that we could use contracts, one of the most elemental legal devices, not just to solve or address some of the healthcare system's most perennial problems, which is high cost, low quality, but simply as an exercise of individual choice. And by the way, the title of the article that Clark mentioned, if I'm remembering it correctly, Professional Norms and Contracts. In many ways, it's the professional norms in that title that are equally as revealing, because of course there was a world, in many ways is still a world, of professional norms, those unwritten ideological inculcated values that really does not consider the perspective of the consumer. The contract is the intervention, is you might say, the lance that can pierce through a world that can be dominated very unconstructively by professionals. So the world of contracts, bringing the world of contracts into healthcare is a incredibly revolutionary idea. And it's one that I am trying to advance, but it's not, there we go. And it's one that's taken on. So this is a ChatGPT question. Why does Clark Havighurst think we need more contracts in healthcare? And we got actually a pretty good answer. Addressing contract failure, empowering consumers, challenging professional dominance, enabling competition, curbing overspending. You know, that's kind of right. I mean, not only right that it actually, ChatGPT is capturing the intellectual spirit of Clark Havighurst, but it's actually right in that those are the kinds of things that we need contracts for.
So now I see how you write all those articles.
It's very helpful, yeah. So I'm now going to talk about a category of research that I've been doing with a bunch of colleagues, many started at Duke, with a bunch of other places, that is exploring this idea of what role contracts are playing in the healthcare financing, in the world of healthcare financing. And basically, the observation I'm making is that Clark might have been too right, or maybe we need to curb our enthusiasm a little bit. This, you might say, is Clark 2.0, or a second-generation examination of contracts in healthcare law. So there were 3 basic papers that came out in this spirit, and I'll talk mostly about the first one, which was very much located at Duke, and I'll talk about the next 2 in a little bit also. But here is the problem in one slide. This is the picture. This is the summary. When we purchase something with a credit card, the administrative costs are about 2-3%. That's the cost that we're paying the third party, all the administrators, to facilitate that transaction. I go to the restaurant, I buy $100 of food, and basically 2 or 3% of that transaction is administrative costs. When we purchase healthcare, it's 30%. 30% just of administrative costs. And this is something that has been borne out in a number of different studies. I will just skip to the end to some degree. We've confirmed this on a microanalytic level, but basically it's about 15% goes to the insurer and 15% is expended by the provider simply to get paid. So our questions are, can we measure the cost of administering these contracts between health insurers and hospitals? If we can measure them, can we identify the sources of those administrative costs? And can we develop mechanisms to reduce those costs? And just so you know, we're talking about real money. It's about $125 billion a year just for spending administrative costs for a private physician to get paid. It's just the money you get to get paid. One title we had is how much does this bill cost? It's really how much does this bill cost to collect? So we're talking about real dollars. And the way we started looking at this is very much a Clark kind of approach, looking at the microanalytics of the specifics. And what happens if we look at a specific healthcare contract, a contract between a payer and a provider? Well, this is a fairly typical one. You have some general provisions that are 17 pages, and then you have a whole bunch of appendices that are closer to 33 pages. And some of this happens to be a contract with Blue Cross, but it's representative of others. A lot of the contract includes what we can call open-ended language, which basically says if Blue Cross decides to change the rules to administer this payment, then they have that unilateral prerogative. So looking at this contract is kind of interesting. It begins with, okay, Blue Cross pays this hospital 200% of Medicare. That's where it begins. But then you see all of these individual carve-outs with specific numbers. This is contracting. Well, for this particular service, we're especially good. For this particular service, we're not quite as good. And we're coming up with very specific numbers, very specific prices for individual CPT codes. And we see an elaborately complicated contract that emerges. What providers have to do to manage these contracts is to follow this provider manual, which basically says, here are the rules you need to follow to get paid. It's 500 pages long. And this is for one insurance contract, designed for one. These are the rules that one payer, one provider, one physician office has to follow to get one payer to get paid by one payer in one contract. And just if we look at Blue Cross of North Carolina as an example, they have 7 different plans. So you basically have a manual for each of the plans that doesn't include it, and then the other private plans, it doesn't include the state plan or even cooperatives and union plans. So what we decided to do is, and I realize I'm already running up on time, so I'll skip through this quickly.
It's a heavy administrative load.
It is a heavy administrative load. Well, we got a lot of details. We decided to simply look at how much a particular physician office spends, mostly in personnel hours, to get paid. And we use a method called TDABC, which is time-driven activity-based costing. We first come up with a process map. It's kind of a how a bill becomes a law into like how a bill becomes a check. Looking at what a provider has to do. And then for each individual event or activity, we identify how much it costs, down to the minute. And we did this at Duke, and the Duke PRMO is the office that has 1,500 employees whose job it is to make sure that Duke gets paid. It's a gigantic building. It's a nice building. But this is where, this is the resources that Duke, and Duke is not atypical, has to invest in simply to get paid. And this is the process map that we came up with after multiple interviews. It's complicated. There are a bunch of feedback loops. We identify the costs of each step. We figure out what the prices are. And these are the individual totals to get paid for each of these services. And this one's kind of remarkable. It costs $20 just to get a check for a primary care visit. How much does one get it for a primary care visit? $100? We're talking about 20% is spent just to get paid. The numbers are equally high for the other services as well. We tried to aggregate it, and this is the number we came up with, which is pretty close to $125 billion, $111 billion a year. The $125 billion is developed through aggregate sources. We looked at it from an individual microanalytics source, and we came up with the same number, and we're pretty confident, therefore, that we're looking at the right stuff. And these are conservative. Well, why? Why is it so expensive? And we have 2 hypotheses that we test. One is that each contract is really complex, and each payer has multiple contracts. So we did an international study. This is paper 2. And we looked at a number of different we looked at providers in a number of different countries. Some of these countries have single payer, some of these countries have multiple private payer, and we simply did the same thing. We looked at the process maps and compared the process map we got in the US to the process maps in the other countries. And just by illustration, you can see the Singapore process map's a lot simpler than the US map. This is the map we have in Germany also. And in Germany, you have private payers. So it's not just about, this is a lot of people are running with this literature to say we need Medicare for all, but we're finding that that's actually not what that logical conclusion is. And in looking at all the different countries, we were able to identify specific sources of BIR costs, billing and insurance-related costs. We added them all up, and lo and behold, the United States wins. We're number one again. And what's really interesting, by the way, is that blue part, coding. We spend a lot of resources coding. And we're higher than everybody else. So what if we standardize contracts? If one of the problems that we have too many contracts, Blue Cross and all the others are imposing on providers individual contracts, what if we all come together and say, look, let's come up with a particular standard contract with our own terms and billing procedures. You can still negotiate prices individually. You can still negotiate other carve-outs. Legally, we certainly could do it. The world of law has done this before. There was a world where every derivative contract was privately negotiated, individually negotiated, until a whole bunch of derivative lawyers came together and came up with a standard contract, and they created a whole new market. So what happens if we were to do this? And for this is the third paper, we come up with a model, a mathematical model. What would happen if we reduced contractual complexity? What happened if we simplified legal compliance? What happened if we reduced architectural complexity, which is basically the number of contracts? We came up with some simulation. We engaged with a mathematician who did this for us. I couldn't explain it to you. But this is the results. And basically, that first number, 111 billion, that's where we are. You could cut it in half if you have a single payer. We're optimistic about it. But what we found is that you can cut it by even more with multi-payer standardized contracts. And you would still have all the benefits of competition. You would have all the benefits of contractual innovation, but it would happen through a coordinated way where you are simply modulating or modularizing the process of conducting contracts. So, conclusions, we're spending too much on administrative costs. Lots of them are coming from billing and insurance-related costs. We think there are better paths ahead, and we think we know how, which is contract standardization. And here's another lesson. Understanding the law and understanding contracts can help. Sometimes, and I think we've all encountered this, we go into the world of health policy and we say, we're lawyers, we're here to help, and that's not always the most welcome lesson. Well, that's something that Clark, I think, brought to us. The lawyer's insight, understanding the mechanisms for how healthcare financing and delivery actually works is an enormously valuable insight. And that's the insight that I continue with me. One last slide. I'm getting there. Oh, I'm pressing the wrong button. That's why.
Green forward.
Yeah.
There you go.
Maybe a second edition.
Healthcare, but not too many.
All right. Thank you, Barack. All our speakers are operating under handshake agreements. It's a very standardized one with no further details on that. But our next speaker will be Jim Blumstein from Vanderbilt Law and Medicine. Jim has spoken at a number of our events in the past and a contributor, co-editor of the health law casebook with Clark for a number of years. And Jim today is going to talk about how Clark and he introduced a bit of economic thinking in health policy and health law, which seemed alien at the time, and we'll see what impact it had. Jim has a lot of practical world experience as well as academic experience. Had him at one of my events where he pioneered the Medicaid coercion argument that had some success at the Supreme Court about a decade and a half ago. Go ahead, Jim.
Thank you for having me there and here. It's just a total treat to be invited to participate in this event. As for other speakers, Clark has been a mentor, And I think we should also say Karen has been a rock of support for him all these years as well. So I think she deserves lots of kudos. As we go back down through memory lane, I just want to remember, I like to talk about the use of language and how language helps to shape perceptions. We now have a healthcare industry. This was unthinkable when we started 50 years ago. It was considered a taboo topic that economics should have a role in medical decision-making. It was almost like if someone wanted to talk to you about economics, an industry, or making money, or profits, or incentives, that somehow you felt that after they spoke, they wanted to take a shower. This was almost a taboo situation. And so when I first came to Duke 50 years ago, Clark introduced me to this concept, and he is really the pioneer of introducing economic considerations into medical decision-making. And as one of his acolytes, when I was at a conference, when I started out shortly after my time with Clark at Duke, I remember going to a conference, and there was a doctor who said, you know, we want to have someone like you to this conference who thinks that economics has some role in medical decision-making. He says, but, you know, this is not like candy. This is not like economic activity. Economics has no role to play. This is all science, and doctors make decisions based upon science. And he literally patted me on the head and said, it's nice to know that there are some people like you who think that economics has some role to play here. And we believe in academic pluralism, so we're going to have you at our conference, but you should know that we think you're irrelevant, basically, to any of this discussion. So when you think about the introduction of economics into medical care decision-making, we have to remember where the starting point was and how far we've really come since then. I live in Nashville, which in some ways is the kind of the headquarters for for-profit healthcare. And the irony is that some of the people who were pioneers of that initiative use regulatory restrictions to restrain access to markets through certificate of need and so forth. So I want to start off by saying language is important. We talk about rationing healthcare. That's still a powerful thing. Economists talk about allocating resources. It's very ho-hum, but there's notion that somehow resources are scarce and need to be allocated has still considerable political power. So I want to start with discussing different ways of thinking about medical care, where Clark pioneered. The way that doctor was thinking is what I and others have called the professional paradigm, which basically observes the lack of knowledge on the part of consumers and the scientific expertise of providers, of doctors. The professional model substitutes professional control, and this is where Mark Hall talked about professional roles, that doctors are accustomed under the professional paradigm to be substitute decision makers rather than informed intermediaries. Lawyers tend to be see their clients as someone that they inform, but the decision making rests with the clients. Doctors tend to think of themselves as the decision makers. It gives enormous power to doctors, and Clark has been a pioneer in focusing upon this, enormous power to doctors to determine quality standards and ultimately costs in medical care. And so the assumption is that patients are uninformed and that the market cannot function in the face of consumer ignorance. This is the problem of asymmetry of information, but it assumes that patients are ignorant and can't really play a role, an important role. Of course, we know in areas like cars, I wouldn't know how a car works, but I can read magazines and other information intermediaries that help me decide what kind of car I want to buy and and Clark has talked about different information intermediaries. So if you look at Car and Driver, you're going to buy one kind of car. If you're going to look at Consumer Reports, you're likely to buy a different kind of a car, like a Volvo or something like that, or now it's Subaru.
But not a Porsche.
I'm sorry.
Not a Porsche.
Not a Porsche. And not a Porsche. The assumption is that there's a scientific answer to medical problems, and that diagnosis and treatment decisions are not influenced by incentives. The use of incentives was what was deemed corrosive or corruption of medical decision making. And so ultimately, the consequence of these assumptions is the structure that we've had in the post-World War II period, where we have third-party payment and the desirable status, and if you listen to today's debates, you'll hear the same thing, that first day, first dollar coverage is desirable because that doesn't affect levels of utilization. And empirically, we now know, no one would make that claim empirically now, that incentives don't make a difference. Clark was the pioneer in developing an alternative way of thinking about medical care, the market paradigm. The market-oriented response to consumer ignorance is education and improved flow of information. And just as in the market for cars, you can know enough to make informed decisions without understanding or going to medical school for 4 years and post-medical training. The doctors have now adopted the legal model, but typically they've called it under their own terms. Instead of informed consent, which is what we call it, they call it shared decision-making. So that doctors may have a role to play, but it's not an exclusive role. It used to be that doctors would not want to share with patients the important kinds of trade-offs. This contemplates a greater role in decision-making for the patients and a greater role for economics. So, where does that leave us? What we have is different factors now that contribute to the emergence of the market model. No longer would that doctor make a claim that incentives don't matter. He would now say incentives should not matter. That's a different thing. It's a normative claim, not an empirical claim. And there are cases, the first case in our casebook, the Muse case, is where a court leans heavily upon a hospital for including economic considerations. Guess what? The patient's insurance ran out. And the judges seem to think that that shouldn't matter to anybody. And I think the evidence now shows that it does. Cost escalation. We've seen the assumption that there's no moral hazard in this area. And again, I think we've built a system of third-party payment on the assumption that there's no moral hazard. Well, this is very questionable. Economists are dubious and so forth. And here's where I want to get my first slide. How do I do?
Click the green. She's going forward. I'll bring it back. Let's see. It should be. Better be there. Let's see.
Well, this one,
right.
you know,
Okay,
you
went
just
backwards.
missed it.
All right. Well, we'll go around the.
I want that,
We'll go around the block.
that graph.
See what happens when you're wise ass. All right. There you go. One more. That it?
Okay. No, the other one, the graph.
After it?
Yeah, that one.
It's
Okay.
the O and the X.
I'm sorry?
It's the O and the X.
O and
Everybody
the
knows
X.
about the O and the
Yeah.
X.
And so ultimately, Clark contributed not only conceptually, but also as an antitrust lawyer. And I have argued that antitrust is the engine of the market paradigm. And Clark was an early advocate for the importance of introducing antitrust principles. Now, this is an area in which there is now pervasive agreement that antitrust should have a role. When the Affordable Care Act was negotiated, the anti-kickback law was held in abeyance for certain accountable care organizations. But both sides of the aisle, Democrats and Republicans, refused to give any comparable kind of safe harbor against antitrust law. So antitrust law had become mainstream. This graph that we did, this is now 60 years old. Clark and I published this in the Northwestern Law Review in 1975. So it's 60 years, it's 50.
Hey, still got problems.
50, well, whatever. It was in
75.
1975, so it was 50 years. I don't want to dwell too much on this, but this is a graph that shows the cost line and relating costs and benefits. And point Y, to the right of point Y is the atrogenesis. The benefit curve goes down. Between X and Y, flat of the curve, what's called flat of the curve medicine. No one would advocate that. That's waste control. The pioneering thing is to the left of point X that shows, and Mark Hall picked up on this in his book, about the importance of trading off small increments of benefit for high levels of cost. And this was the pioneering point. And Clark was the one who, he and I wrote this, but Clark was the important contributor here. Moving from X to point O, the point of optimality, to move down this quality cost in no man's land. Well, it's not waste control. It requires us to consider that there may be certain benefits that are not worth the cost. And that's cost control. So the quality cost no man's land is quality control, where benefits are traded off as against costs. Now, I have to tell you, this has had a tremendous effect even as recently as 20 years ago, when I was Governor Bredesen's lawyer when we were doing TennCare reform. I presented this graph in a showdown meeting among his staff, where certain influential members of his staff didn't want to acknowledge that economics had any role in medical decision-making, and I brought this graph to their attention. And Bredesen was a Harvard-trained physics major, brilliant guy who made a fortune in the healthcare industry, and he got all this. And he said, yes, that's what we're doing. We're moving down into the quality cost no man's land in our Medicaid reform, TennCare reform. And I was told by his staff, I was not there for this part, so this is hearsay, but reliable hearsay, that legislators in Tennessee would come in and say, what is this TennCare reform? And he'd pull out this graph, and he says, we're moving in the quality cost no man's land. We're moving down to get rid of low benefit services. So for him, it was things like using Tums instead of using something, a prescription for antacids or antihistamines. We were spending $100 million for each in TennCare under those circumstances. So this is a graphical depiction of really the idea that economics are important and cost control, giving up certain benefits. This can't be a taboo, that certain positive benefits are going to be given up if they're excessively expensive and there are less costly alternatives. Tom, can you do the next slide, and then I'll close. Okay. Oh, I did it.
Click green.
Click the green? No.
I think it's the one in front of it. That's why it was going on. I'll get back there. There we go. You want that
There,
one, right?
yeah, that's the one. I don't know if that's visible or not, but this is what came from that discussion. And that is what I see as the next frontier, the concept of medical necessity that embraces two important things, costs and also the acceptability of some degree of stratification. That's in the Affordable Care Act, that we are not going to have a unitary standard for everybody. The Affordable Care Act accepts some level of stratification. Until we get over the idea that there has to be a unitary standard for everybody in the country, we're not going to have serious choice, because sometimes there are going to be different levels of resource endowment, and some of that's going to be acceptable, and the Affordable Care Act accepts that. It says that there can be supplementation in plans. But the key thing here is look at B, if you can read it. And that is that it limits the scope of coverage of Medicaid to the diagnosis and treatment of a medical condition. None of these social factors, more generally, carves out an area for medical care. That is to diagnose or treat a medical condition. Then it says safe and effective, and as Mark in his work has pointed out, safe and effective is a medical concept, but there has to be a weighing of costs and benefits, a real scientific accounting, so that the medical necessity occurs only if there's evidence that there's safe and effective benefits, otherwise no payment. And then 3 is the critical point. It must be the least costly alternative course of diagnosis of treatment that is adequate to the medical condition of the enrollee. That's the critical part. It introduces medical alternatives, into medical decision-making, the concept of costs. If you can do something on an outpatient basis rather than on an inpatient basis, Medicaid won't pay for it. If you can do something that allows you to take Tums or my favorite antacid, Gelusil, which I carry with me everywhere, and that's about $10 or $11 a hundred. Instead of a prescription for an antacid, Medicaid will not pay for that. And so ultimately that got approved by a court. And the idea is that the standard is not what Bill Gates would have for his family or what is adequate. That's a normative judgment. So this is not advocating schlock medicine, it's advocating good quality medicine, but allowing for differentiation based upon private preferences and medical plans. And Clark's notion was that there would be different medical plans in the private sector, and with respect to Medicaid, you don't have to look at the best Blue Cross plan to determine what Medicaid will be paying to its beneficiaries or enrollees. This, by the way, is the law, has been the law in Tennessee for 20 years, and our Medicaid spending has been, and I've had a student working on this actually right now to see if we can trace the effect of the medical necessity definition. It's very hard to do methodologically, but I was able to say with a straight face that a minimum of 1% of savings and maybe as much as 5%, and I think 1% is certainly a safe number, but 1% of a big number is a big number. And this definition has kept the rate of growth of expenditure for Medicaid in Tennessee much controlled. And we have not had to have a tax increase. It's been remarkably successful. And guess what? It changes the culture of medicine, where doctors are thinking always about alternatives, less cost alternatives, and developing technology for lower cost alternatives. So this all traces back to Clark's brave entry into the world of economic considerations in medical decisions, and to take away the taboo status of that and to talk about it realistically the way we talk about it in other areas. So thank you, Clark, for your mentorship and for the important introduction. And I've been an acolyte and kind of carried been the kind of the Johnny Appleseed of this, including the TennCare definition, where I was the laboring oar on this particular issue. And Tom, thank you.
Thank you, Jim. All right, our next speaker is Amy Monahan. She brought the early summer weather from Minnesota with her to Washington. She's at the University of Minnesota Law School, quite distinguished there. Writes on a number of she's able to deal with detail and density, dealing with federal taxation and employee benefits law, some provocative work in what exactly is going on and in regulation of insurers and what medical necessity means today as opposed to what it might have meant at an earlier time. I've told one of my students to listen to her presentation because she's doing a paper for me on AI and prior authorization. We'll touch on that one as well. And Amy, of course, her most distinguished characteristic is she did graduate from Duke Law School in the late 90s, but she's done many things since then. Amy?
Well, thank you very much. Thanks for inviting me to be part of this panel. I did have the pleasure of being Clark's student for a very brief period of time, but I took a sort of circuitous route to health law. So I really came across Clark's work, and in particular, healthcare choices, when I started to really delve into the weeds of health insurance contracts, because Clark's book was really the only source I could find that actually said something about what these contracts look like in practice. And they're, of course, as he recognized, so meaningful. So knowing the substance of health insurance contract has always been really important to my own work. So there's a lot I could say, but today I want to focus on just two issues that sort of lie at the intersection of healthcare choices and my own work. So the first is talking about how health insurance contracts have changed over the last 30 years. And then the second is going to be talking about how we might think about the possibilities of AI when it comes to health insurance contracting, and how consumers interact with the health insurance choice. So starting with the first, what do health insurance contracts look like today? People have already hinted at this, but just to set this up, I want to briefly quote from Healthcare Choices about the promise that Clark saw in health insurance contracting for consumers. He describes the main purpose of the book to define an expanded role for consumer choice in bringing healthcare costs under control, and to advocate greater reliance on private contracts as instruments explicitly memorializing the choices that consumers make, right? And so he talked about many things, but important features were the standards-based coverage terms, right? Health insurance contracts said we'll cover medically necessary services that aren't experimental. That leaves a lot of wiggle room, right? So if your health insurer denies coverage for something, you could appeal based on those broad standards, right? Often doctor-to-doctor conversations about, well, is this or is this not medically necessary? As Mark Hall and others have written about, then when you go to court, you've got this very general definition of covered services that is in play, and courts are often going to default to, well, it should be covered, right? And there's a whole host of reasons for that. So one of the solutions envisioned by Healthcare Choices was to make health insurance coverage terms more specific. Again, to briefly quote, the ideal health plan contract would be a kind of medical textbook reflecting the best current scientific knowledge, and then that would be tailored in individual plans based on the trade-offs that the plan and consumers wanted to make. And so the idea was, by being more specific, you could effectuate real consumer choice in the market. So recent research I did with my colleague Dan Schwartz involved looking at what do health insurance contracts look like today. So they still have that same broad standards-based language. So everyone still has medical necessity in their non-experimental. Interestingly, many medical necessity definitions actually look closer to what you have in Tennessee Care than the standard. So we do see medical necessity being changed in many instances to explicitly incorporate cost effectiveness. But the other thing we see are the rise of detailed coverage rules. So most health insurers have very specific policy documents for very narrow categories of treatment that basically produce a checklist of when something is going to be covered. So I'll use GLP-1 medication as an example. Every plan that covers GLP-1s has a detailed, multi-page clinical coverage criteria document where you basically go down the list and say, we will pay for this drug if 2 of the following things on this list are true. And they go into very fine clinical detail. Some plans only use a handful of these detailed coverage documents. Some appear to have them for every possible medical circumstance. So Blue Cross Blue Shield of Minnesota has 171 separate clinical coverage guidelines. So a few things about the specifics of these. So these detailed coverage rules typically aren't contained in the contract themselves. Sometimes they're incorporated specifically by reference. Sometimes they're just generally allowed to be used. So the contract might say something like, Blue Cross Blue Shield can consult its coverage guidelines in making coverage determinations. Sometimes the contract is silent about these very detailed rules, even though in practice, they absolutely are what coverage decisions are based upon. It's also interesting who drafts these rules. So the largest insurers do typically draft these detailed coverage rules in-house. So they usually consult relevant medical professionals. There is always someone from finance involved. There are actuaries. So some are developed in-house. Some just adopt professional association standards. So for example, for substance use disorder treatment, it's very common to just adopt the Society of Addiction Medicine's coverage criteria. Some piggyback on Medicare decisions. Many buy off-the-shelf third-party clinical coverage criteria. So the big ones are Interqual or Milliman, an actuarial firm, has these that you can just purchase. Who drafts these relates to whether anyone can see them. So when an insurer drafts them themselves, those policies are typically publicly available to some degree. Some insurers just post them on the website. Anyone can go and look at them. Others are only available to insureds after they become insureds, right? Not before. And then only upon request. If the insurance company uses one of these third-party products, they are never publicly available because they're a proprietary product. And so the only way you're going to see them is if you end up in a claims dispute with the insurance company that depends on these guidelines. And I should add, that's true even when state law otherwise requires disclosure of these very detailed coverage criteria. So I think it's interesting to think about the rise of what I'll call hyper-detailed insurance contracts in the context of Clark's work, right? Clark saw promise based on the idea that consumers could have meaningful choice. We've gotten part of the way there by becoming more detailed in certain circumstances in health insurance contracts. But the piece that I think is still missing is the consumer piece, right? So for this to work in helpful, competitive ways, consumers have to know what they're buying, right? And they have to have choice in terms of the trade-offs that are made. Here's where we see things fall apart, I think, in the current market. Most consumers have no idea that detailed coverage criteria exist until they get a claim denied, right? And they say, oh, you can't have that imaging because you don't have the right kind of cancer. Here's our document that explains that. It's 17 pages. Even if consumers knew, right? Even if all of us went out and told everyone we know that you should pay attention to this, oftentimes you can't get access to the coverage criteria before you buy the insurance product. Even if you could get access to it, they're very difficult to understand. They're really written for clinicians. So unless you already have a disease that you're very well versed in, it's highly unlikely you're going to be able to understand what it's talking about. And then the last and maybe most important point is you really don't see anything in the market that suggests insurers are trying to differentiate their products based on these detailed coverage rules. You don't see anyone saying, you know, our coverage rules are yesterday's technology at yesterday's prices or something like that. Instead, by the way, what we see is insurers are using these detailed clinical coverage criteria both because they help consistency and efficiency in claims processing, right? You get the same result across your insured population. By the way, they also benefit insurance companies in the event that they do end up in a claims appeal position, right? Having very clear, concrete coverage rules actually helps them say no to certain things effectively. So we do have that piece. Let me end on a slightly more optimistic note about, so what about artificial intelligence? So AI has gotten a lot of attention in the health insurance space, really on the insurer side of the equation, right? Insurers using artificial intelligence tools to help process claims, process prior authorization, and the like. And I think the criticisms of that or concerns about that are fairly well known. In the interest of time, let me talk about something that I see get much less attention, but I think is helpful to think about in this context of the potential for contracts to create meaningful change. So on the consumer side, I think AI has the potential to really aid consumers in understanding their health insurance contract terms. Like, this is actually a task that AI is pretty well suited towards. You can give it a very large body of text and have it explain it to you. Just like Barack helpfully showed, it can summarize a large body of scholarship pretty well. So I think there is potential to use AI as a consumer decision-making tool to go beyond, you know, what we see in the marketplace now tends to be things like gold, silver, bronze, right? That has to do with cost sharing. That doesn't really have to do with meaningful differences in coverage levels. I could imagine a scenario in the not too distant future where AI can really help a consumer understand trade-offs, you know, help the consumer identify which health insurance option aligns with their preferences, risk tolerances, pre-existing health conditions, financial circumstances, providers, et cetera. I also think it could be used effectively to ameliorate some consumer-facing problems in health insurance. So right now, a big frustration is around prior authorization, right? Your doctor says you need this treatment, you want to start it, the insurance company says, we're not going to pay for that. You then have to go back to your physician for a plan B. I think we're going to see relatively soon AI in the exam room, where real time it can figure out whether your treatment is or is not authorized And it's going to let you have an immediate conversation with your doctor about alternatives. So I do think there's some help there. I also think AI could be used not only to identify alternative treatment options that would be covered, but also assisting consumers with filing appeals where they are warranted. So I am cautiously optimistic that we actually might see technology improve the consumer experience with health insurance. My big question on that is, who has the incentive to build out that infrastructure? Health insurers would be the obvious party to do it. I'm just not sure that aligns with their interests. But I will sort of end as most people did, sort of reflecting back 30 years of healthcare choices. To me, as someone that thinks maybe too much about the content of health insurance policies, to me, Clark's work reminds us that ignoring the structure of health insurance contracts and the incentives embedded within them is simply not a viable alternative. If you're interested in health policy, you have to pay attention to health insurance contracts. And I think we're still trying to solve the fundamental question that was raised by the book, which is, how do we build a healthcare system that is both fair and affordable, in which consumers can exercise meaningful choice, and in which plan design serves patients rather than just obscures their options?
Thank you, Amy. That was too productive. I think of the litigation imperative, which is, how do we get more lawsuits out of this? So why can't we empower AI to represent the other side, to say, we looked at this, prior authorization review, and I can understand it's all biased, and therefore they'll have to go to a court that's also run by Judge Bott in order to reach a final decision. And they'll just escalate into an arms race, and at least the lawyers keep getting paid if they're willing to do the lesser work at a higher level. But let's go a little bit of a lightning round, unless someone has incendiary responses to what was said before. I'll try to trigger a few myself. I will mention that, Clark did reflect later on that things perhaps didn't work exactly the way healthcare choices had, hoped it would. Mark referenced The Matrix. I think that was called I've Seen Enough, which was a good title for a closing chapter along the way. There was another article in 2000, How the Revolution Fell Short. So what was being proposed or sold didn't necessarily find a political market, and political market's clear as well as economic. So in a simple supply and demand sense, and this is what academics do, have we been supplying things for which there was insufficient demand? Or is it false consciousness? What's the disconnect? Maybe great theoretical ideas, and admittedly through a political prism, but what's the gap between perhaps, I sometimes use like a perverted version of Say's law, which sometimes simplified as supply creates its own demand. It actually means that the profits from supplying a new product can pay for the old ones, et cetera. But in that sense, is there just a gap between offering things that should, voila, we want this, but it turns out it's not what people seem to respond to? Thoughts on that from anyone?
I'll start out and just sort of come back to my analytical framing, the concept of comparative institutional analysis, which I don't know if, Clark, you ever use that phrase or that specific denomination, but again, it's how I see the field having really taken hold of these issues and grappling with them. And this discussion has been such a great illustration of that, because it, just on the question of resource scarcity and such, we're not talking about what the criteria should be. Nobody just talked about qualities or what quality level or whatever. It's not what is the substantive decision makers, criterion. It's what are the mechanisms for deciding? Who decides, by what mechanism, and how do we implement that? And that's all very much calling on the tools of what we're calling institutional analysis. But it's not just institutions like the doctor or the employer or the government or what have you. It's an institutional, it's sort of a toolkit of mechanisms. So if we think about rules versus standards and incentives versus rules, we tend to think, well, this mechanism is more rule-based and this other is more incentive-based, and rules can be more specific and more general and what have you. But we take medical necessity, that cuts across the whole, political economic sphere. So you've got Medicare, Medicaid, private insurance of all types, indemnity, managed care, and what have you, all trying to sort of get the right mix of tools. And so this institutional analysis is not just who's doing it, but by what mechanisms that I think create such a rich discussion. So any given sort of tool, contracts in its various versions, more rule-specific versus more standards, it's important to elevate the prominence of that, and that's what Clark did. But it isn't as if, let's say, the adoption of greater specification of medical necessity is the only tool that we have. And so we haven't mentioned consumer-driven healthcare and incentives on consumers, the skin of the game, the cost sharing. And that's been a very important sort of development, obviously, over the course of the last 20 years, beginning with something as simple as the drug formulary. So consumers have gotten used to the idea that there are these three tiers, and your drug is Medicare Part D is entirely constructed around this, and you can look up and see are my drugs in the high tier, the middle tier, or the low tier.
Network and out-of-network providers.
Well, that providers as well, but this idea that so I do think a kind of simple modularization can work, to pick up on Barack's idea. And we also see it with the coverage of preventive services. So we have this, used to have, I don't know if it still exists, but Preventive Services Task Force that grades preventive services on, I think, a scale of A, B, C, D, or something like that. And so we have prototypes for this approach, and I think it's going to require artificial intelligence or some condensation of the best thinking in some institution to apply these labels, and rich debate about how best to do that. But I just think this discussion has been such just a great illustration of how effective I think this a way to approach issues can really be.
Go ahead, Jim.
Let me just follow up on that. There's reasons to be pessimistic if you only look at the debates about prior authorization, which is kind of back to the future. We had that 30 or 40 years ago. It's always, when a decision is framed, and this builds on Mark's point, as yes or no, all the impetus is to say yes. But the debate about the Affordable Care Act showed the power of reframing those questions as either or rather than yes, no. So cost containment used to be something that would be just the green eye shades people would be interested in. But when you look at the way the Affordable Care Act got passed, it got passed because half of the money that was developed came from savings in the rate of increase in Medicare.
Those are on paper. We changed that later on, but officially, to pass it, yes.
But now the debate is whether that deal should be made more generous in some ways. But so that was presented in either or terms. Mm-hmm. Either we're going to cover a certain number of people, or we're going to contain costs and cover a lot more people. And that was politically viable. The same thing was true in TennCare, is that the advocates supported this tough definition of medical necessity because they were able to secure from the governor, not Bredesen, but a predecessor, that all the savings would go to expanding the number of people covered under Medicaid. And so I think that if one can show, and I'll tell you an anecdote in closing, but if you can frame the question as if we can do what you want, but this is the consequence of it, we're going to cut people off or whatever, I think that conversation has won the day in the Affordable Care Act and is still viable.
Well,
Let me just give this example. In TennCare, Governor Bredesen was seeking to cut costs. One of the bureaucrats, senior bureaucrats, didn't get the message, and she wanted to add a benefit, which was not a trivial benefit, but not a super important benefit. I don't even remember what it was. McKinsey was hired as the outside consultant on the merits. And this woman, and she deserves to have a name, but I don't remember her name, came in and her team costed out what the extra benefits would be. And they said, we can do this, but the only tool we have available is to cut people off the rolls. And we will have to cut X thousands, let me make up a number, 20,000 people in order to do what you want. Do you still want to do it? Well, she caved almost instantaneously. The issue was framed in either or terms. She was not willing to advance her access agenda if it meant being paid for by cutting people off from Medicaid. So I think that framing is available, but it has to be shown and demonstrated that there's a benefit that goes along with the tough-minded approach.
Okay, well, there's more than one style of framing in order to bring people up on charges, so let me try another slight cut at this. When Clark was talking about the relative comparative advantages of public side coverage and rules as opposed to private side, the public sector clearly had an advantage if you're just trying to hammer down prices and costs in that sense. And if it wanted to provide more benefits, it had the advantage to handing those out. So the role for private insurers would have been to somehow, at least in his envisioning, alter the style and package of care in a different manner. That's what they could creatively bring to the table. In the current moment of our political discussion, all the momentum is, let's just squeeze down the costs, which the public sector can do. They may transfer them somewhere else. And the private sector goes, hey, this private employer coverage is pretty damn expensive, and they're not coming up with many answers on that front. So what happened to the idea, if it's a valid one, that the way to get a handle on some of the cost curve going higher is to deal with the care that's actually being delivered? Those are units. That's how you do it, as opposed to what the unit price is. Has that boat sailed, or is it just a missed opportunity?
Look, I'll just say that it's interesting to me that both Mark and Jim started off with a fairly positive, optimistic moment. I think that all of us imagined writing an article that began, "I've seen enough," and you know, there is something that, without taking away certain innovations that really have been valuable, both policy innovations and also administrative innovations. There's something that is deeply intractable about healthcare reform that, let's just say, allows me to sympathize with the kind of frustration that Clark expressed after 40 years of really good ideas. One of them certainly is the political economy of healthcare. In most counties of America, the hospital is the leading employer. They are not talking in terms of containing costs. They're talking about trying to maintain employment. There is an extraordinary amount of money being pumped into the sector, both public and private dollars. A lot of the hope, and Jim and Tom, I'm embracing your specific comment about insurers. We really thought insurers could be agents of consumers or of employers, and they haven't been. And I think the answer is fairly obvious, even if tying themselves to the prospect of being an incumbent, of sharing profits with incumbent monopoly hospitals and the like, is just a lot better and a lot easier than trying to exact delivery reform. So I think those specific features are fairly intractable. The number of dollars in the status quo, and the political economy of maintaining those dollars, right down to the number of nurses that you're employing in a rural county. And part of the frustration is not that we don't have a conversation about that is nakedly political. It might be refreshing to say, look, we're making a decision between I don't know, say a rural anesthesiologist's income versus the cost of a new business. We don't talk about that. We talk about ways that Clark identified as a professional paradigm. There are certain decisions that are beyond the scope of antitrust scrutiny, regulatory scrutiny, competition and economic scrutiny, and that can be pretty maddening.
Now, look, I always try to do the other devil's advocate side of this. So Clark was very strong on, and Jim as well, the tyranny of the professional paradigm. Well, if you talk to physicians, they don't think they're ruling the roost. They think they're getting hammered every day. And let me give you an alternative paradigm that's replaced the professional paradigm. It's the political regulatory paradigm. That's more supreme than the local doctors group that can basically have their way. I mean, who's the target in terms of what's driving it? I know we supposedly say all these public office holders want to drive down costs. Well, the costs are going up, and I think that programs actually like those costs to go up, despite the rhetoric to the contrary. So how much of this is a lagging influence of a medical paradigm, or is there a different paradigm that's playing most of the rulemaking in healthcare?
I'll just say briefly that I do think that the protagonists or antagonists have changed. Nobody thought that, for example, the TPAs would be one of the bad guys.
Nope.
But I think the language is quite similar. And I think that's the source. I'll speak by that's the source of my frustration. The difficulty of getting into a very realistic trade-off conversation that Jim somehow or another successfully had with the Tennessee legislature is very, very hard to do. And instead, you're talking in ideological terms that don't allow for compromise.
Okay. Go ahead, Jim.
Let me just add that malpractice, while historically that's been the centerpiece of what we teach, it's now just kind of an included item, not a centerpiece. But medical malpractice is out there. It's been the issue since the Professional Standards Review Organization legislation of 1972, where if you're going to do cost containment, and Mark has written about this, he said, well, the world will catch up to the cost containment role, but the cost of being a first mover is pretty considerable at that point. If you are not practicing in accordance with the controlling standard of care, you're really at risk if there's a medical maloccurrence going on. And so until there's some broader adoption, the malpractice risk is out there, and doctors worry about this. Bill Sage and others have written about that. And so one of the things that Clark and I talked about years ago, and Mark has been involved in a project that we've been doing for the last few years about quality improvement organizations. They have the power to do standard setting that has the force of law. But they've never done that because the AMA has fought that role for these PSROs or now QIOs. And that's what I think the next thing is. We have a model statute that we're drafting for this project where we're going to suggest that states mandate that QIOs that do business in the state take on the federally authorized standard setting role. And so that's going to be the next frontier.
One of the older points of critique in even some of Mark Hall's early work, which I used to live off of, and then Clark's, was to blame the courts.
Yeah.
If only the insurers had some support from the courts, they keep overturning these, contracts and they won't enforce anything. Now, Amy suggests they found a way to get around that by basically creating the rules that bypass the judge evaluation of standards and all the bias in that. Where are we today? Are the courts a problem or kind of beside the point?
Yeah, and so in this, hodgepodge of institutional analysis, we haven't said enough about the courts, the liability standards, but also the enforcement of contract terms. And there's a whole other set of topics that Barack and I have written about, which is the price, the simple price, and the price determinations and usual, customary, and reasonable. So a lot to be said there about courts. Amy's, I want to turn to her because she had some interesting observations about the extent to which these clinical guidelines become determinative in court versus simply some indication. Do you want to fill us in a little bit more from your research? Yeah.
So the answer is complicated because, of course, some plans are governed by ERISA, which has its own set of review standards. Some are governed by state insurance law. But if I were to summarize, I would say that insurers have successfully solved the court problem, as we might think of it, where, of course, if someone is dealing with a life-threatening disease and their insurance company has said no and they litigate it, we can all understand as humans why courts want to find a way to say yes to that, right? In our current sort of hyper-specific insurance contract world, that becomes a lot less possible, and it happens at sort of each level that's available. So you don't just go straight to court, right? You start with an appeal to the insurance company. The insurance company has to follow its own guidelines, right? That's part of the governing document. So it says, look, you don't have two things on the checklist, we do not pay for this. Then you can go to external review, right? Which is intended to be independent clinical review, right? By a doctor in the appropriate specialty. However, you can go to independent external review only on issues that involve medical or scientific judgment. So if I'm just looking at a checklist, there's no medical or scientific judgment involved. So I don't get to go to an independent doctor to have a clinical review. My only chance is now to go to court, which of course, very few people even appeal. Many fewer go to court. But even those that choose, like this is really important, this is life or death for me, I'm gonna go to court, are not gonna win in the face of these specific guidelines that say this isn't covered. There isn't room for what we might think of as a nuanced conversation. And that has pros and cons, right? It's not all one way or another, but you can't have the general, doctor to doctor, this is the right thing to do in this situation.
Okay. Let me try a different cut. Principal agent, a recurring item throughout, many areas of economics, but certainly in healthcare. I know our agents don't have any principals, but the principals have agents, is a question I want to ask. In the sense, and Mark has written about, trust in healthcare decision-making. Well, nobody trusts anybody. I mean, we've got warring factions and patients not trusting themselves, and so defaulting on any experience of someone else. Is there a different paradigm that somehow reroutes the incentive tree so you actually know who is working on your behalf or working for themselves? Or is it literally separate tribes, each one trying to maximize their own narrow advantage?
We've been spending the morning complimenting Clark on the way in which he raises provocative questions, but I think we need to acknowledge Tom. I mean, he's a master at this, and that's another great framing of a question. So just a couple of thoughts. Yes, we definitely need to think about the principal agent problem, and it comes up in all sorts of ways. So we start with the question of why the cost-quality trade-off hasn't caught on, and one reason I think is employer sponsorship of insurance, and that sets the standard that people then expect from Medicare and such. And so we do have some stratification, but it's in the safety net arena. And we all know about employers that you would blame the tax law, but I remind my students that you get your health insurance as an employee benefit. Benefits are there to make employees happy. They don't want to pick insurance that makes people unhappy. And so there is this element of consumer education and acceptance that there really isn't a good mechanism for. and I think it does. I think there's more than what the political economy point that Brock was talking about. The sort of the hard nugget of that sort of professional discretion, I think, does reside in the trust that does exist between doctor and patient. Patients really want that trust, and a way in which doctors fulfill that role is to try to keep these considerations at bay. And so I think that's a fundamental element of the human experience in the medical enterprise that can't be just wished away or what have you. I don't know what to do about it. I do think some of these creative mechanisms like independent review, independent external review, and what have you, held real promise, and I am troubled by this development. When I used to teach this area of medical necessity disputes, I said, well, we have found among the various mechanisms that you have, it's the doctor decides versus the insurer decides versus some ERISA-driven standard of deference to this or that or the other, and you go to court, but that takes 5 years. Affordable Care Act says we've tested out independent review at the state level, and it works, or works better than all the other things, the old saw about democracy. But, and so made it universal. So essentially this external review mechanism is available for any and all kinds of insurance. But it is troubling to me that now the contracting is circumventing that. And so one thing I might want to talk more to Amy about is there a way to reframe the job of the external reviewer to give some scope of contemplation to this? I mean, the way it works now is as she described, but could it be otherwise?
Yeah, and I'll just mention very briefly, the state of Minnesota, interestingly, has a state statute that lets independent external reviewers determine medical necessity and have it govern that coverage decision, even if it's contrary to the contract. Now, that has other issues involved in it, but I think it's a really difficult issue of where that line is between wanting to allow some room for clinical judgment, but not opening up anything you want.
Right, so some way that you could have a review, whether it's a case-specific review or something, to say, is that guideline they're using credible? Is it based on, generally accepted, understanding there's tiers and such? Is it within the broad range of things that are credible or not?
And I will say most states do try to regulate the creation of the guidelines. Yeah. But it's very soft language, as you might imagine. It's like...
Oh, I see. Let me okay, Brock, I want to poke the bear in a different place in a moment.
I'm the bear. So what's being described is a way of trying to achieve contractual perfection. I think there's a there. I think it is possible to have a fully complete contract with adequate review that would get the right answer all the time, that might overcome all of the emotional issues and engender trust in the system. But I don't think it's going to happen. And actually, I think in many ways, AI is going to make it more difficult, because you're not just going to have AI from the user perspective, but you're also going to have AI from the industrial perspective, and they're going to fight each other. In many ways, and Tom, I think this is how I interpreted your question. What we've seen has become an increasingly complicated value chain of healthcare delivery with a growing number of intermediaries. And you can add...
None of them the mythical ones we think are going to help consumers.
None of them. And two things are involved in that. First of all, both intermediaries, which include third-party reviewers, include regulators, all the things that Mark and Amy are talking about trying to get this contract right. I think what we've seen is that the growing number of intermediaries have, in fact, become realize that the data that they get is more valuable than the services they provide, and you have created so many different layers between the individual patient and whoever is on the other side of actually providing something of value, that I think you have the distrust that creates the Luis Mangionis of the world. I don't know what the solution is to the trust problem, But I do think that we really do need to come up with a very different kind of value chain. And you know, to the degree that Mark has described HR officials as not only just wanting to keep their employees happy, but also, you know, they go golfing with the CEO of the hospital. They want to keep their buddies happy also. I think that's actually beginning to change a little bit just because the numbers are too overwhelming. And you're starting to see employers being very, very skeptical of all the intermediaries they've been relying on. And that'll be really interesting because you could imagine a real market shakeup. I don't know what it does about trust. And you might have something like, I guess, the world of private equity coming in and saying, I can fix all this, and not fixing it all. But you do see, I think, some real movement on what has become a very ossified, very costly value chain that I think nobody can sustain anymore.
I've got some other layers in terms of the magical ERISA fix and other folks writing out. But I'm contractually obligated to go to the audience for a question or two. This is one of the requirements of the job. So someone make up a video essay, if you will, and we will go to the audience if there is one. And there's a man out there who might have an idea. Remarkably enough, I believe from Pittsboro, North Carolina.
Oh, thank you. Well, I have a lot of notes here, but to sort them out would be really hard. Let me just go back. Tom told you the title of my book, In Progress. At least it was in progress a while back, and maybe I can get it progress again, but so far. But the title is Medical Care, American Style. But what he didn't tell you is that the capital S in style is a very big dollar sign, right? Yeah. Okay, and now the idea I make a lot about, we need competing styles of medical care. I think each style needs to be defined rather. You talked about too many different completing things. You could work out with a little government pressure to have, say, 3 or 4 styles, all defined in great detail in practice guidelines that the government fosters, subsidizes, and promotes, and that become then the standard for different. And so each employee, each consumer would know which he was buying for, and there'd be a different price at each one, and the prices would compete, I guess. But it would be, with managed competition, you could get somebody watching the contracts to make sure there are no things in there that are traps for the unwary. So I think it's not an unplausible way to go, and I love the idea of different styles of medical care. I think that is a sort of positive idea because you really want people to be appealed to because of the human side as well as their medical needs, and all those things would be helpful. And I wrote in 1990 and 91, I guess, a couple articles on practice guidelines. I have discovered that practice guidelines never went anywhere, that they were absolutely, and you didn't know it. You just thought that with the old excitement was going on, and I was assuming, and I was nearing retirement, that we'd launched a new item that make competition focus on quality in the sense that the research, outcomes research, very carefully done, can tell you whether things are really worth paying for. You have to introduce a cost factor, but there are cost effectiveness, cost benefit systems that are usable. Tom called my attention to an article by, I think, 8 or 9 economists who said, each of them said, I've got a new way of doing quality adjusted life years or something like it. And that I'd love that. And I, of course, have no understanding of that kind of research.
Nor do
but
they.
It is used regularly in public policy decisions of all kinds. Here you're going to give people choice of the policy, they will pay the difference. And if they, you try to keep their subsidies so they can at least buy one level, and then if they want to supplement it, they can go higher. I've liked the notion of tax subsidies that we have in Medicare, in Obamacare already, that you set them at the right level, and so people could get low-cost coverage, but then out of pocket ante-up. So I think that the model is there, and I think more attention. The fact is that the profession somehow spread the word about practice guidelines that was essentially, we won't have cookbook medicine in America, and that's carried out. And I went to look at the accrediting rules for the Liaison Committee for Medical Schools, see if there are any differences. Are any schools allowed to teach the use of guidelines? No way. There's not a single thing that makes that possible. So I'm going to go back to the antitrust laws and break up that monopoly over medical education, which really needs doing. And I tried it in '77. I had an audience before the Commissioner of Education, and Newton Minow was there, the AMA's. He was a guest of my father, who was his former teacher, and made it kind of an interesting audience. But we had a good case. When I said to the commissioner, I said, do you think this liaison committee will credit a medical school called the Kaiser Permanente Medical School? And I think the message was clear. We also found, this is interesting too, just another piece of fact, that Abraham Flexner, who wrote the 19 TED study, and 15 years later started protesting that accrediting was regimenting the industry. And that's fantastically insightful. And that's just a little space. Okay. But those are issues I think there is our models. And on the role of economics, Jim, you'd be interested to know that I wrote a chapter of the book on economics. I started with Kenneth Arrow, who wrote in '63 about, he was hired by the Ford Foundation or something to do a study. And he cited all the market failures, but he sure didn't get everything. He never could focus on the fact that it's really hard to write a contract about healthcare. There's too many pieces and things. And that's the problem we're talking about solving. Yeah. One more thing, nobody mentioned the review of my book by Jamie Robinson. Anybody remember in Health Affairs? Go look at it. It starts out.
Your Wikipedia entry gave him a Nobel laureate, by the way, one of the errors in it.
Well, the first line was.
Another Jamie Robinson.
His first line was that Clark Havighurst is a radical. And then he told me how I was trying to clean out like Hercules, the stables and all the stuff that he made a whole paragraph of that. And I was pleased to know, maybe you don't know, that Jamie Robinson got a Nobel Prize.
No, it was a different Jamie.
They took it away?
No. They misattributed it. It's another Jamie Robinson at Cal Berkeley. I've looked it up.
Oh, is that right?
Yeah. That just quality of what you see online. If it's online, it must be true.
But the other Jamie Robinson's a good guy too, though.
Yeah.
But your wiki entry needs editing.
Yeah.
Can I just say, I think that you're exactly right in the sense that we do have a model. It is conceivable and it could work. I think that we haven't talked enough about antitrust.
Yeah,
I think it'll be really hard to do that when we have a delivery system that's concentrated through a hospital that has enormous market power. And maybe we can figure out a new way to rewire referrals. We can use telemedicine in a creative way. We can actually create really vibrant competition between hospitals. Hospitals are wildly different from one another, in spite of the fact that they all try to say that we all follow guidelines. And maybe we could talk about different styles of healthcare that are not just actuarial styles, more than just bronze, silver, and gold, but actually where differences in quality and approaches and philosophies can be emphasized. But to the degree that we're all going to the local hospital, and there's only one local hospital, I think that's going to be really hard.
That's going to be really hard, but I always like to make sure I've blamed everyone. And the one party we have not yet blamed are patients and consumers. You know, he said the TPA and the insurer for the employers, they're just giving them what they're happy for. Well, they are happy with it, even though they may be not getting good care. Where's the bubbling demand saying, oh yeah, we like lower prices, we like it to be paid with other people's money, and we like more benefits. But where are the economizing consumers out there who are saying, this system is taking us to the cleaners and we need someone else as our ally? Are they false sense of what they're about? Or is it simply, you know, there's no barking there because that's not what people want?
Well, they have subscribed to narrower networks through the healthcare exchanges. And so
That's because that's all that's offered, and they used to be able to make economical, except for fictitious people in Minnesota. I have to get that in. Which case, the sky's the limit, right, Amy?
And I have to contractually add, as the tax person, there's also a tax story to why consumers might not be as economizing as we
I'm
might
just saying,
otherwise
we're
expect.
talking about helping them out to find their better alternative styles of care, and ask a person, I'd like to get a lesser standard of care and I'd like to get less. If I can think I can buy a lottery ticket through a political mechanism to get more, and they'll do it. Go ahead,
Let
Jim.
me just say, one of my former students has one of his business models is that he contracts with companies to explain to employees who have substantial out-of-pocket expenses whether that MRI is really worth the cost in these circumstances, along the lines that you've talked about for insurance companies, on the individual level. And so he markets himself to companies so that he becomes the informed information intermediary for them. And his comment to me, it's anecdotal, of course, but his comment to me is, when people are facing out-of-pocket expense, it's remarkable how much they want information as to whether that extra test is really worth it or not.
Right, and that is the slice of shoppable services. We can argue about their dimension as to how far they go.
Right.
But the big money in the big complicated illnesses, that's not a matter of shopping around for the lowest cost provider.
Well, there's stuff been written about this. I don't know why I didn't take it on. So Clark and I actually wrote an article about combining managed care with consumer-driven. Consumer-driven gives the individual a stake in this choice that the employer is making for them. But nothing ever came of that. I also wrote another article, probably my least cited. Can something be negatively cited, like this is not worth reading? I think it's in the minus.
Cite yourself. That's the way to do it. I've learned.
that said, you conceivably, it's just almost a thought experiment. Can you write insurance contracts such that consumers choose their essentially quality cost level? So I want qualities up to the level of 50,000 per, or I want the 100,000 per qualities. And you know, if you could write the contract that way, they could choose alternative styles, and then you could define those styles with behind-the-scenes guidelines. So there's a great idea.
No, they're great ideas. The problem is the business case for making it come about.
Even better is the acronym. It's budgeted risk preferences. We said we need an acronym, so we came up with BURPS. All right.
Okay. All right. We're going to need to call things to a close, unless Barack was exited for a moment. I didn't want to cut him off before he came back. But I hope you can welcome this edition of Mount Rushmore of Health Policy. And, you know, we got 3 spots left on the mountain, so people can keep auditioning. We'll see when we come back. Thank you very much.
It's like a Squid Game.
Oh, my gosh. The Squid Game of healthcare.